Healthcare encounters are a very important setting for suicide prevention. We've known for some years now that many people, typically half or three-quarters of people who die by suicide or attempt suicide, have seen a healthcare provider in the previous few months. But those healthcare providers often may not have been aware of that risk. We also now know that very simple methods, simple questionnaires, several of them, can accurately identify people who are at high risk for suicide attempt or even dying by suicide. So screening at healthcare settings is an important way to identify people who are at risk, especially people we may not have known about. A health system that has an established process for screening at old-fashioned in-person visits needs to think first about the technological or logistical part. If we were using kiosks in a waiting room, or we were using paper and pencil questionnaires in a waiting room, what do we do when the waiting room is a thing of the past? Typically, we're using our EHR patient portal, the capabilities of those patient portals to send out questionnaires prior to visits, and automating that process. If we care about screening, we automate it so that it happens consistently and we aren't relying on providers to send out questionnaires themselves. When something can be automated, it should be automated, and we should make the right thing as easy to do as possible. The technical process we've set up at Kaiser Permanente Washington is that our standard monitoring questionnaire goes out automatically before any virtual visit, a telephone visit or a video visit. That monitoring questionnaire includes the 9 questions of the PHQ-9, including that last item about suicidal ideation. It also includes a few questions about anxiety symptoms, alcohol use, drug use, including cannabis use. When one of our members fills out that questionnaire, and on that 9th question of the PHQ-9 reports that they have thoughts of death or self-harm more than half the days or nearly every day, they automatically then receive the first few questions of the Columbia Suicide Severity Rating Scale. Those questions are served up automatically within the questionnaire function of the electronic health record. Those questions are then delivered using the electronic health record functionality to the inbox of the treating clinician. If the score on that Columbia Suicide Severity Rating Scale is 3 or higher, meaning at least a moderate level of risk, that same questionnaire is sent to the nurse in the mental health clinic or the primary care clinic, or if it's after hours on weekends, it's sent automatically to the consulting nurse service. So the idea is that people who express some concerning level of risk may need an immediate outreach. If they fill out the questionnaire the day before their appointment, they might need to get a call that evening as opposed to waiting until the appointment happens the next day. We have standard outreach protocols when we feel people are at risk of calling a few times, sometimes trying to call emergency contact people if we have such information available. Outreach and engagement is about expressing concern and offering help rather than making threats. So we need to make sure that the message is, we saw that questionnaire you filled out. We're very concerned about you, and we'd like to try to get you the help you need as soon as possible. Please do call us back. And I think when we talk to healthcare systems about this, one of the things we need to emphasize is that this is just like a lot of other things that you already do. So the same way, if there is a critical lab value, a laboratory value that's considered to require sort of possibly some urgent intervention that's delivered after hours or on weekends, there's already a process for sending that lab value to the consulting nurse service and saying this person needs a call and someone needs to check on them. This is not that different. If there's some indication of potentially urgent need in the mental health area, it's not that different from some indication of potential urgent need in the general medical area. And I think we need to make this process, or when we think about risk of self-harm, we need to make that less scary and a lot like all of the other things that the healthcare system already does. We expect that in mental health care, video visits or virtual visits will remain a significant part of mental health care for some time. Our leadership actually expects that virtual visits At least video visits and possibly telephone visits may be as much as 50% of what we do in mental health care. The processes that we've developed for identifying people at risk of suicidal behavior in the virtual care environment will continue to be useful for a long time.